This is part 2 of monitoring the patient in ICU. We're going to pick up with monitoring breathing effort and pattern. The PO1 is a type of weaning parameter that assesses ventilatory drive. This is the occlusion pressure 100 milliseconds after initiation of inspiration. Most of the ventilators that have this are the modern day data processor type ventilators, and they have to have this specific test programmed into the software. Less than 6 centimeters of water indicates that the patient is able to wean from mechanical ventilation. The RSBI, or Rapid Shallow Breathing Index, this concerns respiratory muscle fatigue and tends toward rapid shallow breathing. Of course, rapid shallow does not indicate that the patient is going to be successful in spontaneous breathing. Less than 105 indicates the patient is likely to wean from mechanical ventilation. The lower the RSBI, the better, and it's calculated in breaths per minute per liter. So when you put in the tidal volume, that needs to be in terms of liters, not milliliters. So you have to use 0.5 liters instead of 500 milliliters. The vital capacity. This is an effort-dependent test. In other words, the patient has to cooperate with you. And a vital capacity of less than 10 to 15 milliliters per kilogram indicates a need for mechanical ventilation. So if the value falls between 10 to 15, then I think most textbooks say that it requires close monitoring and you need to evaluate other tests besides the vital capacity. The maximum inspiratory pressure, or MIP. You also may hear this called the NIF. This is not effort dependent, as prolonged occlusion of the airway stimulates maximum effort. And in this case, the more negative, the better. Minus 20 to minus 30 is acceptable, but normal is around negative 100. And so what you do here is you occlude the airway somehow, either with a Rascal adapter or a NIF meter, or you do it on the ventilator. But whatever you're doing is you're measuring the pressure while the airway is occluded. And so the reason they say this is it's not effort dependent is because here in a minute, if you occlude that airway, they're going to give you a big strong effort because they're going to be air hungry. And so hopefully this is what results, and so as time goes on, their effort gets stronger and stronger and stronger. This is figure 46-6 on page 1171. This is evaluating work of breathing in part A, and from the same spontaneous breath, the patient receiving mechanical ventilatory support. The dashed lines represent a tracing of passive inflation by a ventilator-supported breath. Areas of work and the pressure time product, which is PTP, are not directly comparable because work of breathing units is pressure and volume, and pressure and time product units are pressure and time. Those differ. The area of effort in the total pressure time product area occurs before and in addition to the work measurement. Monitoring during lung protective ventilation. This is commonly used in the acute lung injury or ARDS type patients to avoid ventilator-induced lung injury. 3 principles are utilized. You limit the plateau pressure to less than 28 centimeters of water. Reduce the tidal volume to 4 to 8 milliliters per kilogram. Use adequate PEEP to avoid the opening and closing shear injury. And permissive hypercapnia is often used as a lung protective strategy to avoid ventilator-induced lung injury. So those are according to Egan. Here are the ones according to the NBRC. And again, these guidelines are so that we don't cause further injury, because it's very easy to damage the healthy lung, and it's even easier to damage the lung that is very sick and has a compliance issue. So small tidal volumes, high rates, high levels of PEEP. Today, that's the way to prevent or minimize the potential for damage. Cardiac and cardiovascular monitoring. The arterial blood pressure. This is something that we always have to be concerned about, right? There's invasive and non-invasive. Of course, invasive is an art line, and so that gives you a real-time reading of the blood pressure. Of course, it brings its own complications with it because you have an indwelling catheter in place that can cause infection, spike attempt, things like that. In addition, when there's an art line in place, you don't have to puncture the patient for blood gas. So you can draw blood out of the arterial line. The transducers on the art line have to be at the level of the heart to have an accurate reading. So you got to make sure those are lined up and it hasn't fallen off and it's on the floor. If it's not at the same level as the heart, it'll give you an inaccurate reading. The non-invasive is just your blood pressure cuff. And so this is a non-invasive type. And most times in ICU, these are hooked up to the cardiopulmonary monitor that's above the patient on the wall. And they'll program them to run every so often. So like you can program them to run every 30 minutes. So anytime you're concerned about the blood pressure, you probably need to reach up and cycle that blood pressure cuff on so that it gives you a recent reading. Because the one that's displayed up on the monitor is the one that was taken at the last reading, the last scheduled reading. So many times we have to go ahead and cycle that blood pressure cuff again to get a more recent reading. If your patient has an invasive, an art line in it, they will also wear a blood pressure cuff. And so the blood pressure cuff is used to verify the accuracy of the art line. So they will have both. Central venous pressure, or CVP. This is the pressure in the venous system, and it's typically measured just outside the right atrium. Whether you have just a CVP line in or you have a Swan-Ganz catheter. This is the way you have to have one of those catheters to measure it. And I think the typical value here is about 0 to 8 millimeters of mercury. And of course it's used to determine hydration and a number of other things, how well the left ventricle is doing. There's a number of things that affect that. So the pulmonary artery catheter is a high risk to return ratio, so only used in most critical patients. The pulmonary artery catheter is a catheter that's fed through the heart and the tip of it rests in the pulmonary artery. This thing has a balloon near the end, not at the end, but near the end of the catheter. And beyond that balloon, there's a pressure transducer, in other words, a device that measures pressure. And so when you inflate that balloon and measure the pressure there, you're measuring the pressure beyond the balloon, not behind it, but beyond. And so this is the way many times that we get some of the pressures. Now the pulmonary artery pressure is measured when the balloon is not inflated. You can also use this for cardiac output monitoring or cardiac index. Cardiac output is done by heating the blood by a heater that is built into the Swan-Ganz catheter, and it's back up around the superior vena cava in that area. And so it heats it up, heats the blood up, and then it has a temperature sensor on the very distal end of the catheter. It will measure the temperature and do a calculation what happens as the blood moves after it's heated up, the blood cools down, and the amount that it cools down is converted into a cardiac output. And of course, the cardiac index is just the cardiac output related to the body surface area. Pulmonary artery pressure is measured in the pulmonary artery while the balloon is deflated. The pulmonary capillary wedge pressure, or you might just hear this, wedge pressure, is measured with the balloon inflated and measured distal to the balloon. In other words, beyond the balloon. And so it evaluates the left ventricular function. Pulmonary vascular resistance then can be calculated along with systemic vascular resistance. This is figure 46-13 on page 1185. This is an example of preload and afterload. Sometimes these are confusing, so you can think of the preload as the tank of the fluid feeding the heart, and then the afterload is the resistance of the vessel to flow from the heart. And on the right side here, this is 46-14 on the next page. This is arterial pressure wave from systolic pressure to diastolic pressure, MAP, and pulse pressure. This is figure 46-15 on page 1187. This is a quadruple channel pulmonary artery catheter, sometimes called a Swan-Ganz catheter. The distalmost channel, in other words, the distal injection port, is for measurement of pulmonary artery pressure. Blood can be aspirated from this channel for mixed venous oxygen measurements. A second channel, which is the balloon inflation valve, is used to inflate and deflate the distal balloon. The third channel is the proximal injection port, which exits 30 centimeters from the catheter tip, is used for CVP, or right atrial pressure, monitoring and fluid infusion. The fourth channel is an extra injection point, which is not present on all catheters, but can be used for continuous infusion of hyperalimentation fluid. As we go across this figure, as you insert this catheter, this tracing tells you where you are. And the way this thing works is you get it into the superior vena cava, and then you inflate that distal balloon that we talked about previously. And so the blood flow just kind of pushes that balloon through the heart. And so you leave the balloon inflated, you go through the right atrium, the right ventricle, and eventually you get into the pulmonary artery, where that balloon, still inflated, wedges into the pulmonary artery. And so that's what you see here in this tracing as it transverses through all of those chambers. Complete hemodynamic profile from the PA catheter makes it easy to determine the cause for altered hemodynamic statuses. In the table on page 1188, table 46-4, shows the expected changes in the hemodynamic values associated with clinical presentation of the cardiac or cardiovascular dysfunction. Basically, when you're looking at hemodynamics, you need to wear your plumber's hat. That's what it's about. It's about plumbing, basically. If you have let's say you have a very long pipe, and you have basically 4 pumps moving the blood along that pipe. What we're trying to do here is we evaluate cardiovascular function. If there's something that's abnormal, we have to find the pressure that's associated with that pump. We have to look at the different pressures and decide which pump is failing or where it is failing, what the problem is, because it may not be a pump. It may be a restriction in the pipe. Maybe it's clogged or something, or maybe my electricity is out to my pump. So that's kind of what we're looking at here. But if you approach it with that idea, then maybe that'll help you interpret that table 46-4 in your book. The neurologic monitoring, this is often difficult to assess because of the sedation that we use. Sometimes to evaluate this, we have to make sure that they're awake, or if they're not awake, at least we've had the sedation turned off long enough that they should be awake. Many times with head injuries, they're slow to resolve. So we also have to keep that in mind if they have a closed head injury or they've had surgery, something like that. We have to be on guard for that all the time. We also may need to obtain history from family, if not the patient, according to their investigating their neurologic status. The neurologic exam includes the mental status, the pupillary response and eye movement, corneal or gag reflexes, the respiratory rate and pattern, the ICP monitoring, and the Glasgow Coma Scale. The Glasgow Coma Scale is on page 1191 in box 46-6. But the pupillary response and eye movement, this is where they shine the light in the eye and make sure they have appropriate eye movement when you turn your head, things like that. The corneal response, this is the white of the eye, right? It's what they'll do is they'll take a Q-tip or twist the end of a paper towel and touch the cornea of the eye. And of course they should respond to that if their neurologic status is intact. Also the gag reflex, when we suction them, they refer to that as gag reflex. Call that a cough, right? So that's many times those two overlap. So those are some of the tests that they use when they're trying to determine brain death also. Monitoring renal function. The kidney functions are to filter excretion of wastes. This regulates fluid and electrolyte composition. Renal failure is noted by the BUN increase of 10 to 15 milliliters per deciliter per day, or the creatinine increase of 1 to 2.5 milligrams per deciliter per day. And then the urine volume. This reflects renal perfusion. And if it's less than 400 mLs per day, it's termed oliguria. And if it's less than 50, then it's anuria. Many times we cause renal failure by placing them on positive pressure ventilation, because as we decrease the cardiac output, then we also decrease blood pressure, and then that in addition leads to renal failure. So we have to stay on top of this. And so many times we give them diuretics, right? Well, the diuretics many times, they will, if their kidneys are in good shape, it will increase their urine output. But in addition, you also lose some electrolytes out in the urine that you wouldn't normally. So you have to stay on top of their electrolytes also. I think nutrition is often overlooked in the patient that's recovering, especially if it's going to be an extended recovery, whether that's 3 days or 7 days or 30 days, because adequate nutrition is the key for healing. You can't heal if you're not getting some nutrition, because basically the immune system is made of proteins, and so without that supplementation, you don't get the immune response. So assessment of malnutrition is important. This includes organ function and muscle wasting. So serum albumin level concentration is the most common assessment, and less than 2.2 grams per deciliter reflects severe malnutrition, shows chronic, not acute change, also altered by sepsis, dehydration, and trauma. Estimating nutritional needs. This is the first step in establishing the caloric need. Basically, you estimate the basal energy expenditure, or BEE. by utilizing the Harris-Benedict equation, estimating BEE. Have different values for men and women. And then you come up with the BEE so that you can then adjust it for the severity of the illness. For the ill patients, often multiply the results by a stress factor of 0.5 to 2.5. So the more ill they are, like a burn patient that would probably require the most caloric intake, you would take the BEE and multiply it times 2.5. The global monitoring indices have a couple of different scales here. You have the Apache and the Apache 2 scoring systems. The Apache monitors the severity of illness in clinical studies. And the Apache 2 scoring system assigns points to physiologic variables on the basis of whether the values are high or low or normal. And they include the temperature, the mean arterial pressure, heart rate, respiratory rate, PaO2, or the A to A difference, and then some electrolytes, WBCs, and Glasgow Coma Scale. Also included in those global indices, you may also include the Murray Lung Score. If you recall that Kurt Shelley, when he was here talking about ECMO, also mentioned that Murray Lung Score, and you can read about that. You can also get an app to calculate it, but that needs to be included in here somewhere. Table 46-12 on page 1194. I'm glad that they have this table in here because I've been wanting to write an article on this for some time now and just haven't got around to it. But causes of sudden distress in ICU. Because many times, when we're summoned to a room because the patient's now in distress, there's a number of things that we have to evaluate very quickly. This is kind of a run through your head type list about what can be going on. Most of the time it's something simple. If it's a disconnect, that's obvious, just connect the tubing back. Or if it's not a disconnect, it might be a secretion issue and you just run the suction catheter and you get them cleaned out and it resolves their distress. But it's not always that simple. So many times we have to run through this and do an evaluation of the ventilator. Let's make sure we're getting all of our tidal volumes back that we're supposed to. And remember, if you can't resolve the situation in a timely fashion or you can't figure out what's going on, then grab your resuscitation bag and bag them. That's always the backup there. That's the reason that bag is there. But anyway, running down the list here. Airway issues, is it kinked? Are they biting the tube? Something like that. Make sure it's in good place. If it's moved, is it out? Is it in? Cuff problems, listening to the neck. Are they leaking? Is it quiet? Kinking of that E2 tube, especially if they're nasally intubated. A foreign body, that could be, and so this would be more like if the patient is not intubated, then maybe they were eating lunch or dinner or something like that, and they aspirated. A TE fistula may be an issue where you have a leak between the trachea and the esophagus. Secretions, as mentioned before, listen to them first thing. It's going to be the first things that we do is listen to them and get them suctioned out if needed. Bronchospasm, again, listening to them, listen for the wheezes, and of course the fix there is the bronchodilator. The pneumothorax is certainly an issue of positive pressure ventilation. We have to be on guard for it all the time, and so this is going to be noticeable by one side of the chest moving and the other not. The pneumothorax being the one that's in the area that's not. And this may be a gradual buildup. This may not be, can be sudden, but again, it may be a gradual buildup too as the pneumothorax worsens. Acute hypoxemia. And again, there's got to be a reason for that, but many times, you can just offer them some extra oxygen, like just engage the oxygen that you use during suctioning, and that might catch them up enough to where it's not an issue. Of course, agitation is always an issue. Okay, so if it's agitation type stuff, then some sedation might be required, Although I'm at the MBRC hospital, I'm always hesitant to sedate the patient if they offer that as an option. Event malfunction, it certainly happens, thank goodness not very often, but that's the reason we have that bag in the room. Same thing with the circuit. If it becomes disconnected or unusable for some reason. Leak or disconnects. Condensation in the tubing, especially if you have a heated humidifier and you don't have the heated wire circuit, then condensation is an issue. And even with an HME, it's an issue if your HME is worth its weight. Inline nebulizers might also be an issue. They may be a source of leak if you leave them in line after they're finished. So we always want to take those out and put them in their bag and make sure that cap closes that blue T. Inadequate ventilatory support is certainly an issue, especially as we're weaning the patient. So we have to be on guard for that if we're weaning them. And patient vent asynchrony. In other words, do we have the sensitivity set right? Do we have the right mode? Things of that nature. So that's quite an extensive list, and so we're running through our head there as we're trying to evaluate the patient as we go into that room because they're in distress.